Hello, who missed me? All right, hi guys, I'm back. This video is gonna be on diabetes in pregnancy. I had intended to do it last week Friday, but I was pretty tired at the end of the week. It was a very long week. In any case, we're here today and we're gonna go straight to discuss diabetes in pregnancy. Yay. Okay, so I'm not going to define what diabetes is. I think everybody knows what diabetes is. Basically, it's uncontrolled blood sugar. And this is going to be about how it affects pregnancy and also how it affects the pregnant patient. All right. So, as far as, so there are two groups of patients, right? Those who already know that they have diabetes prior to being pregnant and either they're getting treatment already for it, or those who have diabetes but are not aware that they have diabetes until we test them in pregnancy. So how do we find out? So those are the risk factors that I had pointed on one of the slides earlier. For women or for patients who we identify with those risk factors, we screen them for diabetes at their first prenatal visit. Okay. And then they can either be positive for having diabetes or they are not, right? If they are not, then they join the group, the rest of the pregnant population who will get a diabetes screen between 24 to 28 weeks of pregnancy. Now, this 24 to 28 weeks is recommended for every pregnant patient, regardless of if they have risk factors or not. So, for every test, there is either you have it or you don't have it. So if you don't have it, pregnancy continues as usual. If you have it, then we have a different conversation, which is what we're having the educational video in that regard. So when we then diagnose, so for those patients who already know that they have diabetes, like I said, either they are getting treatments already or they're already keeping their logs, and when they present with us, we now look at where they are in terms of their glucose or diabetes control and determine if we need to do anything differently. In addition, we'll assess the type of insulin or the type of medications that they are using, because some of the insulins we don't use in pregnancy, and some of the pills or tablets they use for diabetes when they are not pregnant, we don't necessarily use in pregnancy. So those are the times that we would make those changes if there is need for them in pregnancy. That's why, again, prenatal care cannot be overemphasized, or the essence of prenatal care cannot be overemphasized. All right, so for the ones, whether at the first prenatal visit or at 24 to 28 weeks, when we diagnose you of having diabetes in pregnancy, what do we do? In that sit-down conversation, we're going to discuss diet. Of course, everything starts with diet, right? We're going to calculate based on your body weight and how far along pregnant you are, or for your calorie requirement. And usually we'll divide those daily calorie requirements into 3 meals and 3 snacks. Okay. Some places do 3 meals and 2 snacks. I prefer 3 meals and 3 snacks. We'll get to the reasons towards the as we progress. Now, in addition to the diet, right, we'll also discuss exercise, because exercise has been shown to help control the blood sugars. Now, again, every time I say exercise, I'll always make the additional warning. You can start a new exercise in pregnancy, but don't do anything that increases the risk of you falling or hitting your belly. And this is for the pregnancies that can safely exercise, okay? Or for the pregnant patients who can safely exercise during pregnancy. Now, exercise could be something as little as taking a 30-minute walk after each meal. That is significant in helping to control your blood sugars, that some people, when they do that, may not even need to have medications added to control their blood sugars. Okay, so we'll try this as far as diet and exercise for at least 1 week. And in that 1 week, we send you home with a log, which is basically, it can be a sheet of paper, basically, where you write down what your numbers are. Now, for those numbers, you're going to be checking your fasting blood sugar, which is the very first sugar blood test that you do at home, by yourself. before you eat. So the first thing you do when you wake up, you do your fasting blood sugar. Okay, then I use one test. You check your sugar 1 hour after each meal, which is after breakfast, after lunch, and after dinner. Some places do 2 hours. There really isn't any difference. If you're gonna do 1 hour, do 1 hour for the entire pregnancy. If you're gonna do 2 hours, do 2 hours for the entire pregnancy. But don't do 1 hour to 1 hour for breakfast, 2 hours for lunch, 1 hour. Then it becomes confusing and difficult to manage. Then for those numbers, there are goals that we are looking to achieve, right? So for the fasting, we want the numbers to be less than 95 milligrams per DL. That's I don't think the entire world uses that. In any case, that's 95 milligrams per DL. That's it's not the standard, it's the American system. It's not the metric system, basically. So which the metric system will be equivalent to millimoles per liter, which one is about 0.055, which would convert to about 5.3. So 95 milligrams per DL is equivalent to 5.3 millimoles per liter, right? And that's for fasting, okay? I'm going to talk about 1 hour. If you're doing 1 hour, we need it to be less than 140 milligrams per DL, which would be equivalent to about 7.8-ish millimoles per liter, right? And if you're using 1 hour, it has 2 hours. It has to be usually recommend less than 120 milligrams, which would be about 6.4-ish, they're about 6.7-ish millimoles per liter. Okay. Now that's the goal that we wanted, because it's at these numbers that we have found that the risk to both the mother, the pregnant patient, and the babies are much lower. Okay, when your numbers after 1 week of sticking to the dietary recommendations that we have made, and the exercise, if you did exercise, if your numbers are consistently above the goal, at that point we'll discuss introducing medication management, preferably, which is the first line for treating diabetes in pregnancy, is insulin. Yes, it is a shot. And yes, I understand many patients don't like needles or don't like to have to stick themselves that frequently in a day. But every research and every study has shown that insulin works faster to achieving the goals of pregnancy. In pregnancy, it faster than using the tablets or the pills, right? We have found that the insulin crosses to the baby less often, if at all, than the pills or the tablets that we can safely use in pregnancy. And what we have also found is that when we start patients on the pills or the tablets, most patients tend to fail, that ultimately they will require insulin. Now, that means that we have spent time struggling, trying to get you to a goal that we could have easily achieved that faster with insulin. So those are some of the reasons why insulin as a treatment for diabetes is the first line of therapy. Okay, now while I say that, it's not all types of insulin that we use in pregnancy, because some of them have not been tested or verified to be safe for the baby especially. So that's why, again, you discussing especially for the patients who are already getting insulin, discussing with your OBGYN whether the type of insulin that you're on is safe to be used in pregnancy. Okay, so that if it's not, we'll just simply change it. No harm, no foul. All right, so that's as far as management of the diabetes, as far as controlling your blood sugars. Now, why do we need to control these sugars? And this will answer some of the questions where patients have actually said, well, they had diabetes, or they've had 3 pregnancies or so a number of pregnancies in the past, and this didn't happen, or that, something or the other. Well, first of all, you're pregnant at the time we're having this conversation, which is today. So the time that you are in currently or presently is not the same age that you were in your prior pregnancy. You were not in the same state of health in your prior pregnancy. If anything else, you're older, probably a little more chubby, probably a little less healthy. Okay, but that's why sometimes something can be different in your pregnancy, even if nothing else, it's obviously changed. So why do we need for your sugars, your blood glucose level, to be appropriately treated in pregnancy? Think of it this way, that the blood sugar levels, if it's too high, it can act like it's supposed to be food to your baby, but it can almost act like poison, whereby it can affect how the baby is formed, especially for the patients or for the babies of mothers who had diabetes prior to being pregnant. Okay, to monitor those numbers, what we tend to use is what we call hemoglobin A1c. And usually what we have found as far as research and studies has shown that when the numbers hemoglobin A1c is more than 7, those patients have a higher risk of having babies that may have congenital abnormalities. More common of those is the heart conditions, right? Sometimes they may not form appropriately, whereby it's either something with their spine. They also have increased risk of having what we call open neural tube defects, which I had mentioned in the previous video as regards to folic acid deficiency. That is basically a condition whereby the skin covering their spine on the back is exposed and is open, and then their spine is exposed to the amniotic fluid. Okay, so those are some of the concerns or complications of having diabetes in pregnancy. In addition, depending on, for those who have diabetes prior to being pregnant, depending on how long you've had the diabetes or how well or not well controlled the diabetes is, it can affect the growth of the baby. Typically, it makes the babies grow excessively larger. Okay, but in some women who are starting to have complications, maybe they're having kidney failure or kidney involvement from the diabetes, or they're having eye problems from the diabetes, those ones may have a higher risk whereby their babies don't grow well. Actually, their babies are smaller than the average. Okay, so that's why we'd have to keep an eye on how much or how well your baby grows. And so I was talking about risk factors. In addition, the other thing is, now, while the baby is inside, while you're pregnant with your baby, right, and you're having your uncontrolled, say you have uncontrolled blood sugar, the baby is used to having this way too much blood sugar or way too much food, that when he or she is now delivered outside, right, he or she struggles, because now the baby has to now feed, has to actively be involved in his or her own feeding, right, by either breast milk or bottled milk. That transitioning time, they don't really transition very smoothly. So they have, now when they are delivered, their blood sugar drops significantly too low that they have to be in the neonatal ICU unit. In addition, it also has an increased risk of causing hyperbilirubinemia, which is basically the substance that is compounded in your liver that increases the risk of the babies having jaundice. And we all know about jaundice, right? It can affect, depending on what the numbers are, they will need to be under the lights, the blue lights. Hopefully it's rated identified quickly, and it's not too high that they don't have to have brain involvement from the jaundice, right? So those are some of the reasons why we need to have tight control of your blood sugars. More importantly is that if your sugars, your blood sugar level from diabetes is not well controlled, the baby could die while you're pregnant. So they can have either a miscarriage, or you can have a stillbirth, or like at any point. So that's the concern. So this is not, now hear me clearly, please. My videos are not intended to scare you into action. No, it's intended to give you the facts as is, so that you are well advised on how to either advocate for yourself, to understand why your doctor or your OB/GYN, why we recommend the things we recommend. Because what I find is that sometimes, especially for the women who don't think things should be different with their pregnancies, when I've had these conversations as far as the risk of possible complications with the babies, they're like, wow, nobody told them that. And they are more likely to follow along, being part of your care and your decision making. So those are the reasons why we have to be sure, and that's why I'm making this video, so that because it can go really, really bad really quickly, because the worst thing that can happen to any pregnant woman is that you wake up and your baby is dead inside. It's, in all the years I've been practicing OBGYN, it's the hardest moment for both the patient and for us providers, because in all this time I don't always know the right way to say that to anybody, because it's a very sad reality. But we're here to make a difference, right? So that both patients and the doctors or their provider, whoever their provider is, can work together to get in a better outcome. So that's as far as management of diabetes. In addition, especially the other thing we're going to do, because I said that it can affect how well the baby grows, right? So you, the pregnant woman patient, would have frequent ultrasounds. First of all, every single pregnant patient gets an ultrasound at about 20 weeks to see how the baby has formed, how the baby has grown so far. If there is any concerns with the heart or with any other parts of the body, that ultrasound is detailed anatomy, basically to look at every single part that we can visibly see to identify anything that may affect the rest of the pregnancy. Next, at about 22 to 24 weeks, those patients that had diabetes prior to being pregnant, or that we identified to have diabetes in their very early pregnancies before 24 weeks, will have what we call a fetal echocardiogram, which is basically an ultrasound looking at the baby's heart. Okay, remember I said babies or infants, babies of diabetic mothers have a higher risk of having congenital heart disease. Okay, so that's what that ultrasound is looking for to see if we can identify any of those inside, so that we would get the cardiologist involved to see and plan if there is any special meals the baby would need when he or she gets out. Okay, then after that, at about 24 weeks, or usually 20 to 24 weeks, then you'll start to have ultrasounds at least every 4 weeks if the baby is growing appropriately. If the baby is slowing growth, you might start having more frequently at about every 3 weeks. Okay, now in all this, remember that log that I talked about earlier? You're presenting that log to your doctor every week, because we're going to be making adjustments to either your insulin or whatever medication you choose to be on, which again, I prefer insulin because we have better outcomes with it. Okay, to see if you need to be started on medications and how much we need to be adjusting your medications by, based on that log. So you need to be sending us these logs every single week. Okay, now two things would happen when you get to about 32 weeks. Okay, at that point, if you're on medication for the diabetes, we'll start to see you every week, where we're getting an ultrasound to check on the baby's well-being. Remember I said one of the risks of having diabetes in pregnancy is that a baby could die, right? So these ultrasounds and frequent visits would now help us keep an eye on the fluid and the baby's well-being altogether. If everything is going okay, as far as your sugars are well controlled, the fluid around the baby is fine, the baby is growing well, then we'll see you safely till about 39 weeks. Okay, if your numbers are terrible, whereby we are not getting good control either with insulin, then we'll be having more frequent conversations and more serious come to Jesus moment that may determine or make for you to have a baby earlier. Okay, I think that's a brief synopsis as far as diabetes in pregnancy. With this, I hope I've been able to convey why we need to test for diabetes in pregnancy, why we need to monitor diabetes in pregnancy very closely, and why you as a patient need to understand what we're doing so you can follow along. And if at any point, for any reason, these things are not happening, then you can speak up and ask questions. Again, I am your Dr. Ketchy, and will always be here. There would be more questions because this isn't this is not an exhaustive conversation as far as diabetes. But as always, find me in the DM or in the comments. Ask me the questions that you do. If you already have diabetes in pregnancy and you want me to manage it for you, by all means, there is a link on my profile where you can basically schedule an appointment, and in that I can basically review your numbers, send you back recommendations and things like that. Okay. So I think this is a good place to stop. Thank you again for your attention. I hope this wasn't too difficult to follow in any way. If it is, let me know and I'll make clarifications as needed. See you later. Bye.